Today, I'm going to talk about intracerebral surgery and specifically how do we reduce the cognitive damage we do during intracerebral surgery. So when we remove a tumor like a glioma from the supratentorial brain, what we're trying to do is to make the scan on the left look like the scan on the right with the fewest number of problems possible. Now, most of us have a pretty good idea how to prevent hemiparesis. And language mapping has shown that we can preserve language in most of these cases. But what we're not good at is preserving cognition, because in part, we don't understand how the anatomy of it is. And ultimately, when I trained at UCSF, and I think I got very good training, I was taught that there were eloquent parts of the brain and non-eloquent parts of the brain, and you wanted to stay in the non-eloquent parts of the brain and not cut the corticospinal tract. Now, this is all pretty good advice, but it doesn't get you everything you would hope to have. For example, we have a lot of people who have neurologic or cognitive problems that we don't have an explanation for. And a very high percentage of patients have depression, around 90%. And while you might think it's depressing to have a glioma, this is far in excess of pancreatic cancer, which is an equally bad prognosis. So it isn't just a bad prognosis that's making people depressed, it's something we're doing to their brain. Now, ultimately, when we talk about the term oncofunctional balance, what we're trying to do is to first get the tumor out, because if we don't control the tumor, like on the patient on the left, because we're trying to be dainty and avoid any sort of neurological problem, that's not realistic, because this cancer has already caused some of these problems. So we have to get the cancer under control. But there's an important point. While extent of resection matters, it's not worth it. It's not that beneficial to the patient to push the boundaries of the tumor on the right to get one more cc of tumor. The survival benefit is not so great. This is not a cure. And so if we leave this patient aphasic to go from 98 to 100%, we're not doing them a favor. So there's a point we need to stop where it stops becoming in the patient's best interest. And when we tried to think about how do we preserve cognition, I found that there really wasn't a lot of good advice. So when people say that stay out of eloquent areas, that's a great idea. But what about the rest of the brain? It didn't just appear there for no reason. It's not there to suck CSF. And alternately, when people say everything is eloquent, we know that's not true either. I mean, everyone here who's done more than one brain surgery knows that there are trajectories you can take into the brain and parts of the brain you can remove, and the patient's basically fine. So we know that not everything is eloquent. And ultimately, what we need to do is to understand the brain better and to adjust our thinking as we learn where to put the boundaries. So I've written a paper and have given this talk for a while now about how to reduce the cognitive footprint of brain surgery. So the first thing we could do right now is to minimize damage to large-scale brain networks. We can also begin to think about the brain as a global computer and utilize other techniques to learn about where in the brain we should focus. We can use artificial intelligence. I'm only briefly going to talk about this. And finally, we should acknowledge that we can actually change the connectome with non-invasive brain stimulation, and we should do this. So when they say the term network, this is new to neurosurgeons. It's not new to neuroscientists, because they've known for years that there are parts of the brain that are not next to each other, that when you look at their activity pattern, they're not identical, but they overlap a lot. And when we look at the brain and we say, how many networks are there? Well, it turns out there's about 7. So some of these are familiar, like like vision and sensory motor. But we also have networks like central executive, that's in orange, default mode, that's in red, salience in pink, dorsal attention in green. Now, we might wonder where things like language fit into this scheme. And ultimately, if we change the threshold, networks break apart. So for example, if you look in the upper right, the sensory motor system has a face motor part and an arm and leg part. But the default mode network also splits. So if you look on the far left, you see that language is part of the global DMN, but it's actually closer to itself than it is to the core of DMN. So for example, if you look on the right, the parts of the brain in yellow are the core of the default mode network. If you look at Broca's area and Wernicke's area, the language areas are basically closer to themselves than they are to that yellow area in activity. So this gets very confusing because there's lots of ways you can define networks. And so what we began to call it was the big 5 non-traditional eloquent networks. These are the core of these networks. So the default mode network, the salience network, and the central executive network, we call these the control networks, and the dorsal and ventral attention network. These are the attention networks. Now, how we find these really requires artificial intelligence. There's no easy way to do this any other way, in part because if you look at the anatomy of something on when we look at the whole brain DTI, this is too complicated for us to learn everything that's in here. All these twigs mean something, but we only know what a few of them really do with the naked eye, like the corticospinal tract. So this is why tractography hasn't really revolutionized our practice. It's been helpful, but part of the reason is we're not really using all the information that's there. And when you look at things like fMRI, we also need artificial intelligence because this is the raw image. It's not very useful. But even if I showed you that at that crosshair, that's the activity signal, and that's happening at hundreds of thousands of places in the brain, well, that's still not very useful. But what I'll show you is you can find some really important information out. Now, when we start looking at really complicated data sets, it's necessary that we simplify this into what's called dimensionality reduction. This is the easiest and best way to dimensionality reduce the brain, which is parcellated. Now, parcellating means we divide the cortex into different areas based on what they're doing. Now, Brodmann did the first one of these. So that's the first parcellation scheme that really had any traction. But this is a more modern one from the Human Connectome project done on my brain. And every time you see a change in the area, this means that those two areas are doing slightly different things. And so we spent many years studying the scheme, in part because if you look at the scheme, it often we see that there are important areas that sit inside sulci or cross onto two gyri or tucked into clefts of the brain that we don't normally look at. And what it taught us is that the brain does not care that we call this something the superior temporal gyrus. That's not how it's organized. It's organized like this. And so what we began doing when this paper came out is writing anatomy papers. And this got so out of hand that we eventually had to put it into a single issue of neurosurgery because there's so much information here. Now, in order to leverage this, what we have to be able to do is to figure out where on an individual's brain these areas are. And more importantly, we have to be able to do it in a brain that's distorted by tumor. So a few years ago, we made an algorithm that now is the basis of an FDA-cleared software. It's also cleared in Canada, Australia, India, South Africa, and soon the EU. And what it basically does is it looks at the whole brain DTI and readjust the boundary of these regions to address the fact that a tumor may have moved things. So, for example, the algorithm knows that voxel belongs to Broca's area because it connects to Wernicke's area, and this one doesn't. Now, if we have a patient with a tumor, it knows that there can't be Broca's area in the middle of the necrosis because there's no tracks. And so what it knows that it needs to move the boundary somewhere else. Now, what it allows us to do is to study a patient whose brain has been so distorted by tumor and surgery, for example, this patient here where we've removed the frontal lobe, that it still can find the basal ganglia, can find brain regions. And that really brings to the forefront that we can map brain networks. We can see them and we can preserve them. So for example, we've known for a long time that butterfly gliomas are bad. And if you go in there and just take out the tumor, there's a fairly high chance that the patient's going to be worse for that. But why? Because we cut the corpus callosum all the time. Well, some of it is the fact that these tumors dumbbell into the brain. But even if they don't, let's say they're only located in the corpus callosum, which some butterfly tumors are. These tumors make a 270-degree bend around the default mode network. And that's not one of the most important cognitive systems in the brain. So, of course, if you damage that on your way to the tumor, the patient's not going to do well. We can begin to then start to think about tumors like insular gliomas, which basically have tugged the language system, the corticospinal tract, et cetera, as a series of disconnections. So instead of going in there and just sucking blindly with the CUSA, we can see the networks and preserve them. Now, sometimes we can't. So in this particular case, when we look at the fact that this tumor is not only wrapped around the default mode network, but has the salience network fibers, if you look at the bottom, wrapped around the tumor like a ball, then it's really unlikely that we're not going to cut something at least somewhat important. We can save a lot of this, but there's likely to be some consequences. But at least now we have an idea what those consequences are. We kind of know where we should be aggressive and where we shouldn't. And so what we've begun to do is to annotate the connectome. So when I was in college, I worked on the Human Genome Project a little bit, and they always talked about annotating the genome and figuring out what all these things do. So what we did, and we spent the last roughly 10 years mapping areas to this atlas. And so what you do is you take everything, every piece of paper, every paper that's ever cited a point in the fMRI literature, you map it to these areas, and now you have a map of network. I can't go through everything we've studied. We've written over 50 papers on this now, but I'm going to talk about the area that's probably the most useful to neurosurgeons, which is the control networks. Now, this is not new to neuroscience. There are thousands of papers on this. It's just new to us because we haven't been keeping up with this literature. But what the neuroscientists have shown clearly is that there's an interaction between the default mode network, which is what's on when you're thinking to yourself, the central executive network, which is what does things externally, and the salience network, which is the switch between these two networks. And these networks control other networks, the DMN being located predominantly in the posterior cingulate, the anterior cingulate, and the lateral parietal region, the salience network being a middle cingulate and anterior insula network, and the central executive network being a three-part network as shown here. Now, we know a lot about this, and we know that the control networks cover a lot of cognitive processes that have been linked to this. And more importantly, damage or dysfunction of these causes mental illness. In fact, it is the cause of mental illness for the most part. And so while we don't totally understand mental illness, we know these networks play a key role in it. Now, if we begin to look at the how these networks talk to each other, we can begin to start to answer questions like, what happens in the medial frontal lobe to people who have akinetic mutism? And you can see how these networks articulate with each other. They also notice that the SMA is not really a motor area. It's a cognitive area around the motor system. And so we can begin to think how damaging this would prevent you from leaving the default mode network world of thinking to yourself and turning on the active world. Now, again, it isn't just our theory. There's actually a paper in PNAS showing the same exact anatomy. So we call this the initiation axis, and damaging this is like damaging an eloquent part of the brain. There's also networks called attention networks, and they do interesting things. So the dorsal attention network keeps your attention on a task, and when you damage it, your IQ drops, not because you become less intelligent, because you can't focus on the task. And finally, the ventral attention network, which is right-sided only, is the neglect system. So how do we use this information? Well, we're cutting next to these networks all the time. So just because we don't know about them doesn't mean that they're not there. They've always been there, and we've been cutting across them for a long time. Now, what evidence is there that we should try to not cut them? It's possible that it's fine. We know that probably we're doing something wrong in people, but how do we know that these networks specifically are good, important things to not cut? Well, I reviewed a literature recently for submitting to the European Union for a medical device. And ultimately, I found in the last 10 years, there are over 1,300 research papers showing that damage or dysfunction of one of these networks causes a cognitive, emotional, neurologic deficit. And this is across many, many disease states. So it's replicable. So while we can't say that cutting it in your individual patient will cause a problem, it seems like a good thing to not do if you can avoid it. And tractography, while it has some challenges, there's brain shift and whatnot, is a useful tool to protect things that are near your tumor. At least gives you an idea and a reasonable chance of not damaging it. If you don't have any idea where a tract is, you're more likely to damage it. And what we found is that if you look at insular gliomas and insular opercular region tumors, about 77% of the time, one of the known eloquent areas is next to the tumor, which is not surprising. But when we begin to look at the non-traditional eloquent areas, meaning the big five networks, they're in the tumor 98% of the time. So we're always encountering these. And when we begin to look at skull-based surgery and intra-axial surgery, we know that skull-based surgery is very difficult technically, and there's a lot of risk. But one advantage that skull-based surgeons have is that the anatomy is completely known. It's visible to the naked eye. So we don't know, as far as we know, there's no invisible 13th cranial nerve that we've been cutting. Whereas we don't see any of the things that are important in this patient on the right. And so this is really the challenge of intra-axial tumor surgery. We need to put anatomy where we don't see it. And there's a lot of evidence that tractography can help us do that, including a couple of randomized controlled trials, but also just a preponderance of the evidence. This is actually a small number of the papers. And so when I began writing a book about this many years ago, what we were trying to do is say, given what we know about networks, what are safe cuts? So for example, if we have to remove the frontal lobe, where should we stop? And recently we began to build this into a software called QuickTome. Again, I pointed out it's cleared in multiple jurisdictions now. And what it basically does is you tell it what part of the brain you're operating in, and it basically makes objects to put on the image guidance so that you won't hit them. And as people begin to work with it, what we found is that many times the shortest path into the tumor is the wrong one. So for example, in this tumor, that blue arrow shows you the shortest path, and it goes through the dorsal attention network. So a longer path is better. But also when we begin to do really big operations on a big tumor like this, instead of us thinking about this as this indiscriminate blob that we're here to suck out, it's actually better to think about it as a series of disconnections with networks. We may not be able to save all these networks, but the reality is, it's important to note that we're not doing biopsies. We're doing aggressive resections. But you can see here, if you would go in there and take out the basal ganglia or take this tumor out of the default mode network to get a little bit more tumor, it's hard to say these are good moves for the patient. Now, when we begin to think about cognition, it's possible that there's other things here, because higher cognitive functions like math are multi-network functions. And we start thinking about how all the networks can interact, this becomes really complex. And so one way to look at this is to turn the brain into a giant math equation called a graph. So it looks like this. So what you do is you take the DTI, you parcellate it, and you make a calculation of how much every area talks to every other area. And I'm going to show you two things that we've learned by studying this. And we've published a lot of papers on it. The first is hubness. So if you look in this diagram, the guy on the right is the biggest hub on this cartoon, because he's connected to the most parts of the brain. And we know hubs express different genes, they're more susceptible to Alzheimer's, and they use energy differently. So they're different parts of the brain than non-hubs. But who are the hubs? So we studied this and published it several years ago. And what we were just trying to say is, who are the hubs? Well, this is the top 10. And you might not know what all these words mean, but those guys are what we would call eloquent. These would get you the score in the Spencer-Martin scale. These guys should get you the score, but they weren't in Spencer scale. And the bottom line is, hubs are eloquent. The next question we asked was, how often does someone have a hub where other people don't have a hub, an unusual hub? And without going into too much detail about this paper, which you can read, the answer is 7%. So 7% of people have a hub in the wrong part of the brain, meaning in the frontal pole or some weird area. And are these the people that we make worse with surgery when we think a minor surgery in the frontal pole is safe? It may not be for some people. Another question is, when we talk about how the brain interconnects, is what's called path length. So if I was trying to go from those two places, that's the shortest path. But if I remove it, that's not the shortest path anymore. It's a different path. And we know that path length matters, because the shorter your paths are in your brain, the smarter you are, the higher your IQ is. That's been shown multiple times. So what we did is we did an experiment where we basically took the brain and we calculated all the paths and measured a thing called global efficiency. But then we made an algorithm that ran every reasonable brain surgery. We didn't take out parts of the brain on opposite sides of the brain. We took out things that were next to each other. And we did every conceivable surgery to that graph and recalculated global efficiency. Now, what you can see here is this is us doing brain surgery, every possible brain surgery that was reasonably possible on hundreds of individuals, and they all look like this. So what this means is, for example, if you look at that little sawtooth, each one of these lines is a different operation. And you can see that there are operations where it'd be better off to take off more parts of the brain than do an operation where you remove less, but remove certain bad areas. So we spent 3 years trying to figure out how that worked. And this is what we found, which is under review currently. And it ultimately is that there are some parts of different patterns of individuals, we call them connectotypes, that where we can predict ahead of time what is the worst area in that individual, and it's not the same in everyone. So again, this is another reason why artificial intelligence will be necessary for us to really keep pushing this boundary forward. Finally, let's say we cause a deficit, or we know we're likely to cause a deficit. Well, it turns out that there are tools that we can use right now to begin to reorganize people's brains to help them heal quicker. So if you're not familiar with TMS, you need to become familiar. It's been around for 30 years in psychiatry. And what it does is it repeatedly stimulates the brain with a magnet. And what you can see, it makes kind of a field like this on the right. That red area is the area of maximum stimulation. Now, while it delivers a field, you really need that red area over what the target is, what the most important area, because that's the only thing really getting treatment level dosing. And people were afraid for a long time to do this in post-craniotomy patients because of the risk of seizures. I can tell you right now, we've done hundreds of people. We've never had a seizure. This group here in Germany recently published a randomized controlled trial. And what they showed was a profound benefit to doing this in people who have postoperative hemiparesis with a number needed to treat of 2 and a increasing long-term benefit. So the fact of the matter is, this is what we've seen as well, though obviously not within a randomized trial. So we should be doing this. But then the question is, if we want to go past just motor weakness, how do we even aim the thing? Where do we put this? And we can look at resting state connectivity. And what these red squares are, you can see all these little areas. These are different parts of the brain, different parcellations. These are the same areas. And each square tells you how often they're talking. And in a normal person, the language system is a network. So it's going to be red because it's highly correlated. These areas are firing together. On the right is a patient with a glioblastoma in the arcuate and it's blue because the tract is gone. So the areas aren't talking correctly. Well, that's pretty interesting. We can see aphasia, but that is that part of the brain. So we can basically pull that out, stimulate it, and try to make it better. This is a patient that we did that on. This is not a tumor, but an MCA stroke. She's a year and a half out from the stroke, has significant language problems. And we studied her. What we found is that the only thing still communicating with what's left of Broca's area is the right SMA. So we stimulated that. And 4 months later, she grew tracts to the other side. But more importantly, her language improved to the point when she could attend college again. So that's a pretty significant benefit for something that's extremely low risk. So the future is ultimately utilizing adjuncts to begin to figure out how the brain is working and determine where do we aim our therapies to try to take control and wire the patient in a way that's beneficial for us. So thanks, everyone.
Okay, thank you very much, Michael. You know, there's a couple of questions in the chat, especially from Uday.
Yes. So what I'll as far as it goes, if you look me up on ResearchGate, most of my papers are on there for free.
Okay.
So you can find a lot of that. I've also written an entire textbook called the Glioma book, which will get you a long way there. And as far as tractography misleading us, the answer is that while there are false positives, if you use what's called tract filtration, you can often reduce that problem. And the reality is, while there might be some fibers here and there, for the most part, if you've done tract filtration, the gross anatomy is pretty reliable. And so I will say that you can't trust anything blindly off the cliff, but it's not bad. And I would ignore it at your own risk.
Okay, Michael, you can leave your email address if you want with Uday in the chat. And thank you very much for taking the time. Sorry it was inconvenient for you. Thank you very much.
Thanks for letting me go